Okay, so we're live. Hello everyone watching us from around the world. This is universal health coverage in Nigeria, bridging the gap between policy and people. My name is Jonathan Aja. I'm director and founder of Large Academy, based in London, UK. And my background is in, of course, primary care, surgery, and medical education. Today, we have an amazing host with us, Jennifer, who is going to be leading this discussion with excellent panelists. So I'm going to pass the mic over to Jennifer to carry us through this roundtable. Thank you.
Thank you, Dr. Laj. Welcome, everyone. Good morning, good afternoon, good evening, distinguished panelists, colleagues, and participants joining us from across the globe, particularly Nigeria and beyond. Welcome to this important conversation on universal health coverage in Nigeria, where we intend to bridge the gap between policy and the people. We're having this conversation today at a very critical moment in Nigeria's healthcare system. On one hand, we're emerging from the shocks of COVID-19 with a severe health workforce drain and trying to operationalize the key reforms like the Basic Healthcare Provision Fund. On the other hand, we're also seeing renewed political attention to health through the National Health Insurance Authority Act of 2022, which, at least on paper, makes the health coverage a right for every Nigerian. But the reality remains sobering. Nigeria is home to over 220 million people, yet more than 70% of our health spending is out of pocket, one of the highest rates recorded globally. Fewer than 5% of Nigerians are covered by formal health insurance, and we still account for a disproportionate share of global maternal and child deaths, with maternal mortality at 512 per 100,000 live births. And while the Abuja Declaration sets a benchmark of allocating 15% of national budgets to health, Nigeria consistently hovered around 5 to 6%. Nigeria has consistently, till today, hovered around this 5 to 6%, and that makes this conversation not theoretical, but deeply human. Today's conversation is about that woman in Zamfara, in Sokoto, in Maiduguri, who must sell her assets to access and pay for delivery. It's also about the young doctor in rural Lagos, or urban Lagos, who is considering relocation due to poor working conditions, and the community in the suburbs where the nearest healthcare facility exists, but it's not functional due to varying factors. But let's be clear, this is not a blame session. It's a space for honest reflection, constructive criticism, and most importantly, actionable solutions. At the core of universal health coverage means ensuring all people can access health services they need, when they need them, and without financial hardship. The question before us here is very simple and yet urgent. Welcome everyone here. I would like to introduce the panelists to this important discussion we're having today. Co-moderating with me is Mary Beth Ubanwa. Please go ahead and introduce the panelists. Thank you.
Really a privilege to be gathered here. I hope I can be heard clearly.
Yes, please go ahead.
Thank you. So, thank you so much for the privilege to introduce this level of pristine panelists. I will begin by introducing the first, which is Dr. Lazude Eze. So, Dr. Lazude Eze is a public health physician, health policy and management specialist, and sustainable development consultant. His professional experiences in 4 countries, Nigeria, Togo, USA, and Ireland, cut across clinical practice, health services research, public health project management, and health policy advocacy. He has worked as a consultant on many health projects on malaria elimination, HIV/AIDS prevention, cancer control, routine immunization, and polio eradication. health system strengthening, and a lot of others. With support from donor partners including Global Fund, Gates Foundation, USAID, UNICEF, European Union, Open Society Foundation, and a host of others. In demonstration of his diverse skills and versatile nature, he has led the design and implementation of development projects in other sectors including education, governance, youth, and community development. It's really a privilege and we are very happy to have you here, Dr. Lazute. I'll move on to the next panelist, which is Dr. Celestine Emeka Ekulo, MD, MPH. Dr. Celestine Emeka Ekulo is a UK GMC registered physician and public health specialist with advanced master's degree in international relations and humanitarian and refugee studies. He has extensive experience working with UN agencies such as the World Health Organization and UNICEF, and leading international non-governmental organizations such as Save the Children, Family Health International, and International Medical Council and Palladium across Nigeria, Ukraine, and Bangladesh. He has authored several peer-reviewed articles in global health and humanitarian response. Dr. Ekulo led the development of Nigeria's national strategy for nutrition in emergencies, contributed to the national guidelines for integrated management of acute malnutrition, and served on the technical advisory committee for the Nigerian National Food Consumption and Micronutrient Survey. He has also contributed to the Global Compendium for Household Nutrition Indicators, a project led by Johns Hopkins University, and co-led the development of an ethical AI system for young child feeding support in Ukraine, an innovation he presented at the Global Nutrition Cluster. Thank you so much, and a privilege to have you here, Dr. Celestine. Finally, our third panelist is Kingsley Igwebike. Kingsley Igwebike is a public health and development professional with nearly a decade of experience working with the World Health Organization. He specializes in health promotion and communication and has worked in emergency settings like in the Northeast Nigeria. Additionally, his area of expertise cuts across evidence-based health promotion and communication, community engagement, and the use of data-driven approaches to address health misinformation and improve public trust. He holds multiple postgraduate qualifications, including a Master of Business Administration, a Master's in Digital Transformation from the United States, a Master's in Public Health from the United Kingdom, a Master's in Business Management with a specialization in Program Management, also from the UK, and a Master's in Corporate Communication and Media Studies from Spain. He is currently pursuing a PhD program from an American university. Kingsley is passionate about leveraging AI automation and data analysis to inform public health decision-making and proposal development. He's experienced in community engagement, bilateral and multilateral engagement, corporate communication, and public speaking. We are indeed privileged to have this level of informed and expertise here. Thank you for joining. Over to you, Jennifer.
Okay, thank you everyone for being here. Dr. Laz, please confirm you're on the call. Okay, thank you all once again for being here. Let's begin by unpacking the policy and governance architecture in universal health coverage in Nigeria, because even the best interventions can fail without strong systems behind them. Mary Beth, please ask the panelists to their questions. While we're putting ourselves together, we can't hear you, Mary Beth.
Permit me, I was muted. So, my panel discussion is based on health financing and equity specialists. So, we'll be looking at how Nigeria pays for health, who bears the burden, and what financing model can drive equitable universal healthcare in Nigeria. So, the first question is, Nigeria's out-of-pocket health expenditure is one of the highest in Africa. What are the specific policy and system failures that have allowed this to persist, and who bears the greatest burden?
Dr. Celestin, please, over to you.
Okay, thank you so much. Can everybody hear me?
Yes, we can.
Yes, I agree with that. Just before I start our wide discussion, I was trying to make this, as simple as possible with the reality we have on ground. Most of us know, if we are not aware, that Nigeria is one of the highest, country that have out-of-pocket expenditure on health. And we are talking about 70 to 75%. So when we think of that, it means that health practically makes, everyone poor, or at least most of the people poor in Nigeria. And even if you think you're rich, it just takes one sickness, to probably, make you go bankrupt. And this has been happening. It didn't happen today. It didn't happen yesterday. This has been something that's been in place for long. The government have tried to, kickstart or innovate the National Health Insurance Scheme, which I also happened to do a publication on sometime in 2018. And what we find out is that it's a very weak system. Unfortunately, that has not been, not much has also been improved, even up to now. Um, and I want to give a typical example. Now, when you go to the north, I happen to work in the north back in days, I mean, for a very long time, like rural Plateau State, and in Maiduguri, I was with WHO back in Plateau State. You notice that as low as 15 naira, I'm not kidding, as low as 15 naira, you see some women taking their kids home and say that God will take care of them. So you can imagine some poorest family, let's say now maybe that 15 naira could be equivalent of 500, 1,000 naira now. That 500 or 1,000 naira could make, people like give up, that we don't have that extra money to take care of maybe our baby boy that is under 5. Now think of this when we now talk about probably something much higher, maybe a sickness that is requiring a significant amount from the family, because we don't have a system in place. The system we have, the National Health Insurance Scheme, it's not been good. I mean, most people that are in the corporate world and have been able to access it. And you and I understand that in Nigeria, a lot of people are not in the formal sector. That we have a lot of, like say, private business owners and self-employed people. And most of these people don't have, the access to the NHIS, which itself is actually not adequate. So this is one of the big problems we have in Nigeria. Going back to my research, we also found out that even among the people that have, that are registered, in the National Health Insurance Scheme, in will I say dichotomy or how the practices are done, and some of them they are actually a bit shabby. So all these have contributed to increasing out-of-pocket expenditure, which the harsh reality is that it causes the poor to suffer more, and then it drives direct and indirect mortality and morbidity. I know that some states have tried to, come up with maybe state-owned insurance schemes, but it has helped to an extent, but it still fall below the minimum. Maybe we can discuss more on that, so I can also allow other panelists to talk.
Okay. Thank you, Dr. Celestin. So, to add to what you're saying, we know that over 60% of Nigerians work in the informal sector. If we don't solve that inclusion challenge, can universal health coverage in Nigeria ever be realistic?
The answer is simple. The answer is no. I mean, if we look at the National Bureau of Statistics data on the unemployment rates, I'm not even talking about now the people that are working in the informal sector. I'm talking about the general unemployment rates. Now, the unemployment rates in Nigeria is unbelievable. Um, if the MBS could even admit, to this high unemployment rate now, you can, because I mean most times we know that most times the MBS data is a bit of influenced by the government. They don't want to really make the government the present government look so bad. Now now there are two people we are talking about. We are first of all we are talking about the people in the informal sector. Now there is other set of people that are not actually employed, right? If we cannot address this, we've not started. So there's still a big problem. I mean, when you talk about health insurance in Nigeria, there's still a big problem because it's just a mini school. I mean, just a handful of Nigerians, about 220 million. Population, just very high, just few are in the formal sector that actually have access to this national health insurance scheme. So if we've not been able to address what happens to the unemployed, what happens to what's it called, the people in the informal sector, and what happens to even the elderly and all this. And let me use, I know that we are not US, but in US you have the Medicare and you have the Medicaid. One state-owned and federal-owned. One that for people that are old, people that are disabled and all that. If we're not able to, I know we are not there yet, but the problem is that are we trying to make progress towards that place? Unfortunately, no. And if you look at what the minister of health said, I mean, about 2 or 3 months ago, right, when he was someone, he said that just 38 million, I think, for the 2024-2025 budget has been released. I mean, that was why the Minister of Finance was relieved of his duty, was it 2 or 3 days ago? Think about 38 million was released in a budget year, FY, that should be 24-25, for health. It's when I heard this, I was like, am I dreaming? Is this real? That's why I want this discussion to be as, like, let's not go high. Let's bring it to what is happening in Nigeria. Now, we are talking about 38 million for, I mean, billion or thereabout for the whole of, as the percentage was less than 10% that's been released. When that discussion was brought up, and okay, fine, the Minister of Finance has been relieved of his duty, but that does not solve the problem. People have died, a lot has happened, and we are talking about health.
So
So, I mean,
let me lead you to the second question, Dr. Celestine. State, like you mentioned earlier about the state health insurance schemes, we have they vary enormously across the country, from Lagos to Kwara to Borno to Sokoto. We have disparity in the insurance packages. What can we learn from some of the successful schemes, and why haven't the most lessons been replicated nationally?
okay. Now, yes, when we talk about this state insurance scheme, first of all, I must acknowledge that these are good, innovative, approaches. It's always good when we bring that, because decentralizing, some of these things like health, electricity, and all that, it will help to solve Nigerian problem. Everybody understands that. So first of all, I'm not going to say anything in negative about the people that came up with the state insurance scheme. The only comments I have here is the coverage. Again, it's better than none, but the coverage has not been so much impressive. However, does it have, would I say, an advantage? Right? Yes. And what I would encourage, would I say, other state minister of health to do, or people here, I wouldn't know the people in this call. If there's anyone in this call that can maybe somehow, drive some of these questions maybe towards, I know that some of the INGOs work at state level and they have, so a sort of influence, in the state ministry of health. You can give them an example, like, okay, something like in Lagos State, for instance. Let's use Lagos. I mean, I know that most times we use Lagos for a lot of good things that happen in the country. The out-of-pocket expenditure reduced, by I think about 40%, right? Again, like, my only worry is that we understand that Nigeria, the will I say the level of this thing is not equal. I mean, we have about it was only 15% coverage, but the good news is that about 40%, reduction in out-of-pocket expenditure. I mean, that's a very good one. There's another state we talked about, the Kwara state, right?
Yeah.
What happened in the Kwara state when this was introduced? Again, the out-of-pocket expenditure dramatically reduced. Was there any, will I say, was there any hitches or hiccups sometime within the scheme? Yeah, that's good. Yeah, there is. I'm from Abia State. There's never been something like this in Abia State. If there is something like this in Abia State today, I can tell you that some of us will be very glad, to register either ourselves or since we are not there to register our loved ones, one way or the other, except if it is restricted only to the formal sector. So getting the state health insurance, or will I say activating them rather than getting them, activating the health insurance scheme at the state level for me is a very big some is an innovation that if we can replicate this across the 36 states plus the FCT in Nigeria, that would be a great one. And it will be a very big stone. It will be a very big stepping stone towards achieving the or like we always say universal health coverage, but in reality it's nowhere. But if we can get it, I mean, it will be a step, towards achieving the ambitions, the missions, and the goal of fulfilling the objectives of the universal health coverage. Thank you.
Thank you, Dr. Celestine, for this insights. Let me transition to panelist one. Thank you for being on the call. Please confirm you can hear me, Dr. Laz.
Yes, I can hear you.
Okay, we'll be looking at the policy and governance architecture of the universal health coverage in Nigeria. And of course, we do know that Nigeria Universal Health Coverage agenda is embedded in the National Health Act of 2014. And the SDG framework is yet to be implemented, remains fragmented across the 3 tiers of governance. And the Basic Healthcare Provision Fund is currently at 1% of the consolidated revenue, which was meant to be a bold commitment to disbursement and accountability mechanisms, and these have been inconsistent. Dr. Laz, Nigeria passed the National Health Insurance Authority Act in 2022, making health insurance mandatory. 2 years on, this is 2020, 4 years on, how would you assess implementation progress and what structural barriers are still preventing the scale up of this act? Thank you, and over.
Thank you very much, Dr. Jennifer, and thanks to other panelists. I've been listening to everyone. I was on the backstage, actually. It's a delight listening to Celestine, and I quite agree with the points he made that we should be very practical about this, citing some of the experiences he's had. I want to provide some kind of historical background. Before we get to 2022, the health insurance situation in Nigeria. I think the NHIS was through an act of 1999 that established it, but it wasn't until 2005 that it became activated and established as an agency of the Federal Ministry of Health. And from then, it was mainly federal civil servants that certain categories, not all of them actually, that were enrolled into the scheme. And over the years, we had a situation where NHIS, as it was then, was the regulator and also a provider, of course, working with the HMOs. So, and you came to understand that achieving UAC wouldn't be possible when there is no policy framework that makes it mandatory for every Nigerian to have health insurance. For several years, a simple question such as how many Nigerians are insured, didn't have an answer. It's, until recently that we started having numbers of 19 million, 20 million, 21 million. But then it was often 5%, we threw that percentage, or about 1 or 2%, less than 5%, as some people would say. for several years. I recall asking a former ES of NHIS how many Nigerians are covered, Professor Yusuf, I think, on two different meetings, and I didn't get an answer to that question. So, coming from there in 2022, the NHIA was passed to be an improvement on the NHIS. At least, I think Section 14 provided for the mandatory coverage, which is good policy wise. You know, from then till now, almost 4 years, where are we? Has there been substantial improvements in terms of coverage? Maybe yes, somehow. Last year, there was a pronouncement by the president uh, directing that all categories of federal civil servants should be covered. So, which is like an expansion of what it was at the federal civil service level. Then the creation of the state health insurance agencies, which was facilitated by the Basic Healthcare Provision Fund, because it's a requirement to access the fund. That's essentially why the states were had to set up those agencies. Has also kind of added numbers, and beyond the Basic Healthcare Provision Fund, the number of states have gone ahead to get use the adoption method, where people, even political actors, can take up a number of persons and they will sponsor their insurance. For example, if it's 15,000 naira per annum, someone can choose to pay 15 million to insure perhaps 1,000 persons. So those things, pockets of those here and there, has kind of taken it to the current number, though disputed in some quarters. But at least NHIA says about 19, 20 million or thereabouts in terms of number of persons that are currently covered in the country. Uh, so coming to where we are now, where do we go from here? I think perhaps other questions, responding to that, I'll be able to provide some specific response to that. But the policy framework, in my view, is there. So right now, it's no longer a question of policy gap, especially at the federal level. But at the state level, yes, we could still observe those gaps. The agencies exist, uh, but in terms of practice, I do not think the agencies are getting optimal support. In some states, the only resource that goes to the agency is just the money from the Basic Healthcare Provision Fund, through which they are providing health insurance coverage, prioritizing children under 5 years and pregnant women. It doesn't even cover other groups. The Vulnerable Persons Fund, which is also created by the NHIA Act of 2022, has not been activated. It doesn't exist. This is a fund that is supposed to cover vulnerable people, including persons with disability, elderly people, and people without jobs, and also low income earners. So it's supposed to have contributions from the government, development partners, perhaps some taxations and stuff. But as we speak, 4 years into the act, it's not yet been activated.
Okay,
I
let me
know
cut
what
you on track.
what we went through.
Mhm. Let me cut you on your track, Dr. Laz. So
Okay, thank
you're saying that the Basic Healthcare Provision Fund is meant to be a game changer for primary healthcare, right? In your assessment, how effectively has the Basic Healthcare Provision Fund been deployed, and which states are doing it right, and why?
Okay, thank you very much. Yeah, the Basic Healthcare Provision Fund, created by Section 11 of the National Health Act, yes, is a game changer. But between the intent and what we are seeing, there's still a lot of gap. I happen to be one of those who pushed for the passage of the NHI, National Health Act 2014. And I recall advocates we had to push for 4 years between 2014 and 2018, when the Basic Healthcare Provision Fund first appeared on the national budget. It was a whole lot of engagement at the level of National Assembly to even operationalize that session. And the first release didn't come until May 2015, that there was released to Abia and Oshun that were used as pilots. So we made some progress. But in terms of the use of the funds, mine is that of huge disappointment, knowing what is supposed to be and what I've observed in some states, where those funds are not fully released to health facilities. In fact, I know some states where the idea is for the health facilities to get those monies directly by themselves, get directly into the account. All the health facilities have account that the OIC or the officer in charge and the chairman of the World Health Committee or World Development Committee are co-signatories. But what happens in some states is a situation where they go to the state capital, withdraw cash, and some of those monies are shared among some corrupt officials of state health, primary healthcare agencies, and perhaps whatever is remaining, they go to make use of. There are a lot of sleazy deals going on here and there. But I'm glad with the reports we are getting from Abia and Niger, and also Lagos, as Dr. Celestine has cited. The Niger State Commissioner for Health is a colleague that we've worked together in some immunization projects in the past, and he's the one driving that process. It may also be that because Niger is one of the states that piloted the Basic Healthcare Provision Fund ahead of other states, so those early lessons may have helped. Abia is quantum leap. I happen to be a member of the Transition Council for the Abia State government in 2023, and my contribution was on health. Prior to that time, I had visited the state, visited some health facilities, and I was doing a TV show then. I was too ashamed to put up some of the things I saw on TV, but in recent past, the government, they are retrofitting health facilities, introducing some technology, equipment, some telemedicine facilities, and some of them are coming up, and we are witnessing some good progress, despite existing gaps. So for these days, Lagos, yes, in terms of human resource, Lagos is quite advanced, much more than many other states. There are human resource people who are very well educated and also, understanding some of these issues, and there appear to be systems at the state level that provide some significant support. And also, given the nature of Lagos, there's huge resources to power a number of things. So we've made some from where we're coming from. At least one gain that Basic Healthcare Provision Fund helps is to make the World Development Committees to be stable, because while I worked with FHI years ago, we helped to supported communities to set up WDC, supported their meetings under the Health System Strengthening Project. But as soon as the project ended, everything collapsed. Even to hold meetings, they couldn't. So, but now with Basic Healthcare Funds, they at least see reasons to meet once in a while. But the feelers I get in some states, they only meet when they hear that fund has been released. So at least to come and discuss how to spend the money. So
Okay, Dr. Laz, let me pick you up on funding, the amount that is being released. They convene when they hear the money has been released, and they come around the table to discuss how to share that money. Recall that this money is meant to improve service utilization, improve quality of care, and also provide essential services. If to look at this deeply, we'll see that the governance structure is deeply federalized and it's fragmented at the moment. How does the intergovernmental complexity at the three tiers of government, especially at the LGA level, which is meant to fund the PHCs, how does this structure hinder the path to universal health coverage? And who should be driving this agenda? Over.
Yeah, thank you very much. Starting from the last question, who should be driving the agenda? I sincerely believe that the states should be driving the agenda. Federal provides policy framework. Federal should focus more on supervision, supporting supervision, monitoring, and evaluation. Federal should be doing annual assessment of performance of states and doing ranking. State performance rankings. So that people will see how well they are doing, and of course, disbursing monies. One of the things, maybe because of a lot of funds coming from the national are like, okay, donor funds. At state level, they are so used to this project-like approach, and any money coming seen as free money. The Basic Healthcare Provision Fund is not meant to be a displacement fund. It's complementary. It's supportive. And the Act also specified that the state and LGAs should provide counterpart funding of 25% each. I can bet that majority of the states are not providing counterpart funding to even access these funds, and if you withhold it, it will cause problems. So the federal still had to disburse. So the fragmented this thing, I wouldn't want to use the word fragmented because we don't run a unitary system; we run a federal system. So there are responsibilities for each type of government. So at the state level is where most of the actions happen. Ideally, the LGAs should be in charge of primary health care, but the PAC under one roof policy has essentially, in most of the states, brought all primary health care under one roof. And that one roof is the Primary Healthcare Development Agency or Primary Healthcare Development Board, as some states call it. So with that is the state governor that appoints the executive secretary of those agencies, and it's the agencies that hire staff, it's the agency that is in charge of monitoring and evaluation, policy wise, everything is done together. And it was a response to fragmentation at the primary care level, where some LGAs will be paying salaries, others will not be paying. So there was a lot of confusion in the primary health system across states that made that agency, the primary health care under one roof, to be done. But still, unfortunately, all the states have agencies, but not all of them are operating primary health care under one roof the way it's designed. There's one of the states I support in the northern Nigeria, and even some states in the south, that yes, there's an agency, but it's not the agency that hires, the primary healthcare people. It's still the local government that pay them. So it's just appeared that they set up an agency just to be able to be seen, because there was a scorecard that was produced and some states were scoring 0, 5%, and it was shameful to some of them. So they just had to do the act to set up an agency. So it's still some kind of barrier. But if all the states can activate and fully operationalize primary healthcare under one roof, and the states also, with the state health insurance agencies, put funding into those agencies and also significant funding into the primary healthcare development agency as well as the health insurance agencies. Both has to work together because the demand and supply side of UHC is there have to be facilities to provide these services. People will not have the confidence to go and buy health insurance if they have the money. When the health facility in their locality is not functional, when they go down, they don't see people to attend to them, or when they see people and they don't have the tools to attend to them. So beyond the monies that is put into insurance, it has to be matched with the supply of these services, with providing the quality of care that people can have confidence in.
Okay, let me ride on your response. Thank you for such insight. So, based on human resource inavailability, we have seen the brain drain in the health sector, which has precipitated the crisis, right? From a policy standpoint, what concrete measures can Nigeria implement to retain health workforce while expanding access to services? Because it's one thing to provide services, it's another thing to have the health workforce to provide this to the users. So if there's access to healthcare facilities and there's no access to healthcare workers, that is a crisis. So with the brain drain, this has been a very critical topic across the health sector. Brain drain. How do we address this? What are the governance structure to put in place? What are the, from policy standpoint, what concrete measures can be put in place to sort of synergize these gaps, closing on these gaps? Thank you, and over.
Yeah, thank you, Doc. I like the language you use, crisis. The human resource for health is a crisis. Yeah, is in my view the biggest crisis we have in the health sector at the moment. And looking at what can we do to solve it, we need to look at the root cause. Was actually the problem? Why are people leaving? A number of studies have been done to try to find out why people are leaving, and significant among them is not just a health sector issue; it's also the overall governance issue. A lot of people are losing faith in the quality of governance in the country. They are losing hope in their future. Remaining in Nigeria, the security situation, the quality of life, and other things. So, and those who have the opportunity to leave, like healthcare providers, take advantage and jump on it. If vulcanizers or shoemakers have the same opportunity, we'll probably also be shouting brain drain among, shoemakers in the country. So ICT people, because also at some point the banks also crying that they are losing a lot of their ICT experts, who are leaving the country to work elsewhere. So having made that point, as it has to do with overall governance, if more Nigerians believe that they have a future in Nigeria, more Nigerians who have opportunity to leave may think twice and not want to leave. Now, coming specifically to the health sector, the poor remuneration, poor working conditions are also part of it. So even for those who are staying, um, they don't feel they are getting enough. Take, for example, when I was doing housemanship in 2009, they were paying us 180,000. That was when they started commerce implementation. 180,000 was around 1,200 US dollars, in dollar terms. So you can finish house jobs, save up enough money, and some of our colleagues who prioritize buying cars, could buy Tocumbo, Corolla, or Camry around 800,000 or 700, you know. So, and those who wanted to live had enough money to write exams and do other stuff. Right now, house officers are earning 276,000, you know, converted in dollar terms. It's not, your guess is as good as mine. So it's not even up to $200. I think $100 is maybe about 100 and something thousand. So it's not even up to 200,000. So if you save up the entire money in a year, it's not even enough to buy a fairly used Nigerian car. you know. So that tells the story about remuneration. And why wouldn't such people go elsewhere to seek this thing? So we need to look at that. We need to pay people what is worth, because medical practice, be it doctor, nurse, physiotherapists, all over, countries that prioritize the health of their people are ready to spend, and get workers anywhere in the world to come and provide it. So that also speaks to the political will. Nigeria spends a lot of money, Nigerian government, but what are we spending it on? So we rather spend trillions on things of interest and allow medical workers to go on strike for days and weeks, sign an agreement that they will still renege on. So that strong political will need to be there. There's also low risk of health perception among the citizens. Uh, Anything that becomes topical, that becomes an election issue, the politicians tend to pay attention to it. Nigerian people, everybody, oh, it's not my portion, so I bind, I cast and bind. So we feel that we won't be affected. We are just okay as long as we are not currently ill, or our family members, our friends are not suffering some of these things. We are okay. We don't want to be part of the conversation. We don't want to push for it. It's the health workers, it's their job. So because of that low health risk perception amongst citizens themselves, health issues is not a priority. Nigerian Health Watch around 2014, 2015 did a poll to ask the people what are the top 10 issues that is important to them in the 2015 election cycle. Health was not among the top 5 things that people mentioned. So, with that attitude, those people also become leaders, and we see health from tokenism aspect. Oh, free medical outreach. You see leaders acting as if they are NGOs, government acting as if it's NGO, it's a humanitarian, is a dash kind of stuff. Meanwhile, health is a serious business. So that approach is one of the things that is making it see it as charity. And people who are providing this very important, seeing money invested in health as money you not get back. And that approach makes them not to see it as an investment that you reap, not just in terms of naira and kobo coming from hospitals or health sector, but as something that the whole system benefits from. So tackling those things from the roots are things that will help to reverse it. The government has taken some steps in the past 2 years. There's this policy the Ministry of Health made. They kind of put some barriers that makes it more difficult to leave. You need to get some clearance from the ministry. They put some administrative bottlenecks, that kind of makes it the journey longer. The low pay is also making it that people are less likely to afford even monies. The dollar rate has gone so high, so many people's money cannot even afford it. And they increased the quota for medical schools in terms of the number of medical personnel they will train. They kind of doubled it. Some state like Lagos, I read setting up additional medical school, but in my view, it's like, okay, your basket is leaking. You're pouring a cup of water and it's leaking. And you now say, okay, pour a gallon to the same basket. It will still leak. Maybe what might change will be the duration of time it takes to leak. So while those are okay, appears good, but I don't think it's going to solve the problem. So it's not only federal government that will solve it. A lot of states are not hiring people. Those that are available are also being overworked. And very importantly, primary healthcare is not working in a lot of places. And when it's not working, there's a lot of pressure at the tertiary care. So you go to teaching hospitals, it's like a market square. That's a place that should be attending to heart failures, kidney failures, orthopedics issues, and people working there having enough time to provide quality service for those complicated cases. But while they attend to that, they are still attending to cough and catarrh and acute uncomplicated malaria, and people get so overworked and exhausted.
Yeah.
You know,
So,
so
Dr. Ladd,
yeah.
thank you. Is that to say that the disconnect between financing and performance is actually a driving factor to inefficient service delivery model?
Absolutely. The finance is not performance based, and there's also no kind of measure to even track our performance. In working systems, even performance of hospitals are being tracked and people are held accountable. There's really no accountabilities. Whenever a high profile person suffers medical negligence and he makes the headlines, we take some knee-jerk reactions, pretend to be doing something, looking for scapegoats, and we still go back to status quo, waiting for the next person. So
Dr. Laz, I just wanted to add some points to the important ones you've made. If that's okay, or if you need more time, I can just wait.
Please go ahead. Thank you.
Yeah, so I agree with Dr. Laz. So I think the federal government in Nigeria is funny. I mean, as someone that works in the UK, you cannot stop anyone from leaving to anywhere. And I repeat, like, you can't do it. Why? Because even if I were to take £150,000 and become educated, there's no law, human rights law, that can prevent me from going to work anywhere. That's one. So you would breach people's fundamental human rights. I can go into long details. The only people that get paid properly for the work they do in Nigeria. Of course, you correct pay with the economy. It's only the politicians. So if they take that same approach across, and look into the things, and I think Lars has made a good discussion that our politicians and the people, the populace themselves, do not value their health. And that's why you would have national insurance that only covers 8% of the population. So the healthcare is chronically underfunded. And you design a healthcare in a country that has a lot of oil and resources. We have some of the smartest people in the world. Yeah. We have some of the most resources anywhere. And then we have people that they would rather spend their time to promote tribalism, incompetence, and of course come up with scapegoatism, and then they would expect private hospitals to do the job of the government. It's the government's responsibility to provide healthcare. And any government that the first three things they don't address is healthcare, jobs, and human capital development. So, but for Nigerian politicians get away with this all of the time. So there is the NDC candidate. He's running for office. I wanted him to come and I'll give him some opportunity to address this. But the point is, the reality is the law with which we fund healthcare in Nigeria needs to be repealed. So we need someone like Trump. You need to repeal the law and make health insurance compulsory. Now they will tell you we don't have data of the informal sector. It's a lie. Why? Because if you look at Nigeria, about 60-70% of the people have a phone number, either Glo, MTN, what. So you have the data. So to come and make the argument, we cannot collect health insurance money is a lie. You just need to put negative debit, on their phone number. And once you have, this is the laws they should be making. Now, once you've, of course, collected the money, the second thing is you cannot have institutions where people do as they fit. You get me? And the reason why it's continuing that way, you can't come to, like in the UK, there is a storm now. Mendelssohn, which is English, was failed vetting. Yeah, about 6 people have resigned. Yeah, the prime minister may go. Nobody's discussing that, Mendelssohn is English or is Scottish, so we should leave him, or he's Irish or he's Welsh. We have this idea, because if you go across England alone, you have about 18 accents of English, just in England. So this idea that, because it's a very tribal country, it shouldn't work, is just garbage. So the NDC aspirant, I have a few questions for him. And my first question for him is a pharmacist, Emmanuel, is why is there a chronic overlook? Why is it that Nigerian politicians don't, and the populists, why is it that there's little value in the provision of healthcare? I think that's my first question for you. This is live, and so the people in your constituency would watch this. Emmanuel, over to you.
Yeah, thank you so much, Dr. Jonathan, and it's good to be online with your audience. Hi, everybody from around the world. It's my extreme pleasure to speak on this platform. My name is Pharmacist Emmanuel Amodu, the NDC candidate for Ankwa Olamaboro and Omala Federal Constituency. So just to reiterate your question, why do our politicians don't care about healthcare? It's a lot of theories, but I will start from my experience. Our politicians like to control us. Our politicians like to keep us at their mercy. So they always like to see us begging. And it pleases them. It brushes their ego when they see the citizens on their knees, the citizens begging. Because if you check it very well, you and I have worked in the Nigerian healthcare space. Some of the problems are problems that even a few £100 can solve. Basic electricity, provision of safe hygiene factors, hygiene environment, paying doctors as when it's due. You can't pay doctors, but you are buying expensive jets, you are buying a few other things. So for me, it's a culture that needs to change, and it has to change from our generation because we have been exposed. We have seen how things work everywhere, and we know what our people need. Also, the factor that provides that the journey that people take before they become leaders in our country is a journey that we also need to investigate very well because most times the best people do not rise up to become leaders. Leadership in Nigeria isn't for the best and the resourceful. It's for the most wealthy. And most times, when they take loans to invest in their election, they end up recouping those loans. So they could recoup those loans in any way by maybe trying to change the health sector or trying to create an atmosphere where people are not getting the best services and then they could make one or two things from that process. But for me, it's our people, it's our culture. There's a big man syndrome here where a rich man wants to have poor people at their mercy, begging for favors. We need to change that.
So let me quickly add a second question. Why is it that we have incompetence at home and excellence overseas? So you see the same Nigerians. Why is it that we have incompetence at home and excellence overseas? And I can name people and people. So you start with the Okonjo-Iweala, yeah? World Bank, Ngozi, Adesina, what's the guy? Ogunlese. There's so many. Why is it that we allow incompetence at home and we promote excellence overseas? So which is something I think we must start to think about. I don't know whether Laz and Jennifer has some. Why do we have so much incompetence at home and so much excellence overseas? Which should be the other way around. I just showed you William Harvey. That's his lab. Yeah, William Harvey is dead. How many years? That's John Vane's lab, the person that did aspirin and all of the work, and he's still here. In fact, when I was moving around, we went to St. Bartholomew's. That hospital has been there for 900 years. So I think my question to the panel, I don't know who will take it first. Why do we promote and encourage and tolerate incompetence at home and do the reverse overseas? Is this a self-destructive tendency? What are some of your thoughts around it?
Okay, I'll go first. I think it's a structural thing. So we have in us the ability to actually get these things right, but the structure in place is not built for us to actually put it into practice. So when Nigerians move overseas, where there's a system in place, and then there's also conducive environment for the skill sets to be well showcased, then you see us perform better. That gives you a very clear window into the disparity between home and away, home and abroad. The environment is not built to retain talent. So when people migrate, you see the talent on full display. Over to the panelists. Kingsley might have something else to add. Okay. Dr. Celestine?
Okay, what I would say is it has to do with structural failure, you know, and again, there's an argument I've made. I know that I mean, some people might disagree with it. Will Nigeria get better someday? The answer is obviously yes. How many years will it take? I don't know. Maybe I project about 300 to 500 years from now. So I know it sounds funny, but yeah, we'll get there because when you look at some of these countries in Europe too, they've been there for long. There's been mistakes and all that, and they gradually got it right.
No, but Kingsley, what are the things that says we are getting there? If you look at the metrics, we're really losing the milestones we've achieved. That's my concern. We're not, if the milestones we're not moving forward. You know, the Naira keeps losing again. I can list a whole bunch of metrics. The roads getting bad, the corruption is getting bigger. Now, majority, in fact, they are promoting for, what's that called? People sending money home to Nigeria you have politicians like Ben Mori, Bruce, praising it like some. Nigeria is the only country that does that kind of. It's garbage. For instance, you won't hear Saudi saying, "Oh, you know what? We're sending all of our professionals abroad so that Jonathan will send money to his auntie, and their way you would get dollar in the system." You know, so that's my concern. So if you say we may get there, it may just take us longer. The metrics, what metrics do you see that you think is showing that we would get there in this amount of time?
Okay. I was just discussing with someone yesterday night. I want to use my state as an example. That's Abia State. I witnessed the military regime, and I also saw the when Ojo Zokalo. I mean, I was already in secondary school then when Ojo Zokalo took over the reins of power in 1999. So at times we might tend to lose hope and all that, but for me, from what I've seen so far, unfortunately, like I said, unfortunately, it's not going to be fast. But taking my state as an example, it's as if all hope we are lost already, but somehow we are back on track. Look, something like the administration will come. When you look at the Obasanjo administration and the Jonathan administration, especially the Obasanjo administration, we really made progress. In a lot of things. Jonathan administration was laced with a lot of corruption and all that. But amidst all that, there were still progress that was made. Unfortunately, Buhari took us backward, and here we are looking at an administration that I would want to comment on, so that this doesn't become so political. You know, but these guys will come and go, and gradually somebody. I mean, it's a system. You are going. It's a country, so we are going to get there. But unfortunately, like I said, we are not looking at 10 years, 20 years from now, because I mean, this is 8 years by age. So it will definitely happen. Will I be there by then? I wouldn't know. I spent some time in Ukraine. I read their history. I saw what happened. It took them years before they were able to get there. Unfortunately, this is my own argument. I know that everybody might not like it, but this is just my own argument.
Okay. I mean, you can assess each of the governments that we've had. They've not moved us forward, and we can go metric by metric, but it would probably derail. But Amodu is here; he's running for office, and yes, the citizenship. Yes, please, yes.
Oh, okay. Thank you. I like how interactive the conversation has been. It's a pertinent question that you asked: why promoting incompetence at home and excellence elsewhere? And people have said there is system structures. Yeah, I agree partially. We have structures, we have systems, but it's not the functionality within the same system. Here in Nigeria, there's also disparity between private and public. So if you work in Luth, there are some things you do and get away with it that you will not get away with in Lagoon Hospital in the same Lagos. So within the private sector, health sector in Nigeria, we have, it's just that here you don't make a lot of you cannot advertise health facilities. You can't do promotions, but there are health facilities that are doing exceedingly well. COVID-19 did something. It forced the big men to know that those health facilities, those hospitals exist in the country, because they are used to flying out. So when they couldn't travel because of COVID, they had to use that. And say, we didn't know there's something like this in Abuja. We're in Lagos, in different parts of the country. And those hospitals, they grew. Some have even expanded, built bigger stuff, and they are doing quite well. So I think what is lacking is accountability. We have a system where people do things and get away with it. And if you have any leader or any administration that is accountable to itself and begin to hold everyone accountable, people will adjust. A doctor here will more likely relax on some things when he knows, oh, nothing will happen. And elsewhere, you are afraid of lawsuits, you're afraid of losing your license. It's just simply accountability. Everybody is being watched. Even those working in government hospitals here put up a different attitude. The same individuals go to do PP over the weekend in a private hospital, puts up at the opposite. It's just accountability that makes the difference. And when we begin to hold enforce accountability at every level, I think things will change, and it requires leadership that is values accountability, showing those examples to make it happen.
Excellent. So my question to Amodu, you are running for office. If you become a House of Rep member, how would you make people accountable? So I understand you are legislative, so they are not your direct employees, but how would you make people running the healthcare at every level accountable? Yeah, how would you make people that have stolen public funds accountable? How would you deal with the forces? Because the reality is, look, the only reason why you have excellence overseas is they won't take it. Hello, in the UK, they won't take it. In America, they won't take it. The only thing is, like Lars has said, when you say accountable, if you steal our money, if you steal their money in China, they will hang you. Now, if we would kill people for no reasons, then why not give the corporal punishment for the right reason? So the question is, you are running for office. Tell us, the world is watching. How would you ensure that this accountability is palpable? Can you hear me?
Seems we lost him.
Yeah. Yes.
We'll put that question in the parking lot. When he comes back on, you'll have to respond to that. Thank you so much for the very insightful questions. That makes it more interesting. Your questions actually highlight the economic realities behind universal health coverage, and we need accountability. It's good Emmanuel is running for office because we need to put this clear dichotomy between accountability and impunity. The people at the helm of affairs are operating with impunity, and we need to take a step forward to demand accountability from those in governance. I would want to quickly dive into the panelist number 3. Kingsley, are you on the call? So
yes, please.
Ultimately, health systems are not experienced on paper. They are experienced in communities. Let's move from policy, financing, and governance, and then look into what people actually experience on ground and in person when they access care at the health facilities. In your experience, Kingsley, working on the front line of health delivery in Nigeria, what is the single biggest gap between universal health coverage promises and what the communities actually receive? What does this gap look like in practice? Over to you, Kingsley.
Thank you so much, Jennifer. And interestingly, I'm actually tempted to say one or two things regarding the aspect of accountability, but then in the interest of time, I will try as much as possible just to be laconic to respond to this question. So I think responding to this, it's an interesting question, to be honest, and it's quite refreshing listening to each one of the panelists right here on the call. And one thing that I thought to reiterate here, I think the problem, one way or the other, isn't at the policy level. It's actually at the implementation, particularly at the point of care, right? Because policies are amazing. There are amazing policies. As a matter of fact, in 2023 or so, there was a qualitative study done and it was published on BMJ. One of the things they found out is that the current health policies is actually driving amazing health reforms. This includes the National Health Act as well as the Basic Healthcare Provision Fund, which of course we've all talked about briefly here on the call. All these contribute towards the advancement of universal health coverage, but there is a massive deficiency when it comes to practicalizing that, which is really concerning. And a couple of weeks ago, I came across an amazing article. It was a research done in one of the states in Southeast in particular. To avoid stereotyping, I would try as much as possible not to mention that. But then one of the findings made is that caregivers, they tend to feel as if it's a routine when healthcare workers ask them about pay whenever they approach the said primary health center, those people working at the community level to provide services. They feel it's a norm for them to really pay in order to access services. But in terms of policy, it is expected that some of these services at the PHC level, they've been subsidized. But when they get there, they're either asked to pay informally, of course, and what have you. So for the gap, in terms of the gap, we've seen promises when it comes to the UAC and the aspect of financial hardship as well. But then clearly one thing that I think it's a major concern at the community level, particularly because the PHC is the first contact when it comes to the community receiving care. One thing that tends to be a major issue is the insufficient fund, the lack of proper infrastructure as well. It's an issue in my opinion, and also lack of dedicated workforce. And I'm really happy we've talked about this during the discussion phase in the previous questions while addressing some of this issue, and also limited.
I'm not hearing anything. Is it just me? Hello, I'm not hearing Kingsley.
Hello,
Okay, it's like we lost Kingsley.
can you hear
And
me?
yes, I can hear you now.
Yes. So basically, I thought I was being heard earlier, and I invariably concluded. But then, just a final thought, and I thought just to reiterate, I was really happy the point you made, Dr. Lars, on the aspect of the low risk perception. This is also a major issue because it's a concern at the community level when they really do not see the importance of prioritizing their health. So as a result of that, of course, it's generally an issue one way or the other, aside the whole aspect of the insufficient funding, lack of workforce, as well as the limited medicine. So that's low risk perception amongst the members of the communities is really a major issue, and that's somehow a bit difficult in terms of accessing the whole scheme when it comes to the universal health coverage. Thank you so much.
Okay, thank you, Kingsley. Looking at last mile delivery, let's look at the choose. They're somewhat meant to be like the backbone of primary care delivery in Nigeria. Are they being adequately supported and deployed? What are their potential, and what is holding them back? Now, let's be very careful with the way we respond to this particular question, and that is because when you look at the healthcare worker cadre, it's quite different across the different parts of Nigeria. For instance, in Lagos, the primary center is manned by a principal medical or a medical officer, and then you have the nurses and midwives providing other levels of care. while the CHUs are at the vaccination points, administering vaccines and taking data. Then you go to the northern part of Nigeria, the CHU is manning the entire PHC. In some other cases, the PMOs are at the secondary level, manning the secondary healthcare facility, the general hospitals. And you know that this is actually affecting the way primary care is being delivered across the country in terms of equity, in terms of quality of service, even service delivery. For instance, in Sokoto, a CHU is administering misoprostol, which is not supposed to be, which is an institutional problem, so to speak, because they are not supposed to be able to administer oxytocics at that level, right? So what do you think about CHUs generally and how they can bridge the gap in providing access to primary care? This question is actually going to go across the entire panelists, but I'm going to start with Kingsley's response before we go to Dr. Laz and Celestine. Thank you.
Thank you so much, Dr. Jennifer. So I think before responding to what exactly is holding the CHU back, I thought to draw inference from two amazing studies really made, I think, a couple of years ago, 2 to 3 years or so. The first one was specifically for Jigawa State. Of course, it's just like the state Jennifer made mention of. Jigawa is still within that particular confine to some extent, for better words. So the study was actually published on PMC, and it demonstrated that the deployment of CHUs across the rural location, of course, 2 by 2, has contributed in increasing health utilization generally across those particular locations. These include the aspect of antenatal care and also facility-based deliveries. I'm making this inference to reiterate the importance of CHUs, right? And also in one of the states in South in particular, some of the CHUs that are under the supervision of a medical doctor, there have been an increased provisioning of quality healthcare services and real time as well. And a survey has revealed in the said article revealed that at least nothing less than 86% of patients express their satisfaction when it comes to engaging with these said CHUs. And from experience, CHUs generally play a pivotal role when it comes to increasing risk perception and also increasing demand for immunization services at the community level. I could remember one of the states where I was privileged to work to support. There was a bit of an issue, a rift between the vaccinators. It was more like a campaign, the vaccinators and also the community leaders. So the CHU played a massive role in dousing the whole issue, because they understood the terrain, they understood why the whole immunization stuff is crucial. So because of that single heart, and based on data, there were a lot of zero-dose children and also under-immunized children. So the presence of CHUs really breached that gap in ensuring there is access, and the immunization team were able to reach out to the say targeted children. So what exactly is holding the CHUs back? I think I will still have to go back to the amazing points Dr. Laz really made on the aspect of remuneration. This is it cut across, to be honest, and we don't want to really flog it. It cut across the aspect of remuneration, because if they are intentionally taken care of, I think they will be increased. They will not just be motivated, but they would really go the extra mile to ensure quality. They're doing an amazing job, but it's just to reinforce what exactly they're doing. And I think one way or the other, just like Dr. Jennifer made mention of the aspect of where you could see a CHU carrying out a particular services that is outside of their scope. I think inadequate supervision is also suboptimal, because if there is an increased provision across where the CHUs are being operated, capacity will be built, and on-the-spot mentoring will also be provided, whereby the CHU would play really a crucial role in strengthening the capacity of generally the primary health center, and also the aspect of insufficient supplies. This is also what I think one way or the other is also holding them back. Another point that I also thought to make before I pass the mic to the next panelist is the aspect of geographic isolation. This issue. We've all talked about this during our discussion, but I just thought to remind us that this also contributes to why the Jews are not really maximizing their presence one way or the other. They're doing an incredible job, but I think one way or the other they could even do much better in ensuring the PhD services at the rural community in particular become one of the best across the country. Thank you so much.
Thank you, Kingsley. Thank you so much. You answered the question before I answered you. I wanted to say that what would it take to unlock the potentials of choose to scale at scale? Would it require curriculum design? Would it require some additional level of training, especially now that we are having digital tools being rolled out at different levels, being integrated into service delivery? I was trying to preparing my question, but somehow you have touched on that. So
nice. So I went ahead.
Yes. Over to you, Dr. Laz. Do you have additional comments for Choose precisely, considering they play an important part in service delivery at level?
Yes, absolutely. Thank you, Dr. Kingsley, for those very valid points. Looking at Choose, have Choose, J Choose, we need to remind ourselves by design what's their primary responsibility. The primary health care, community health extension workers. At some point, we used to have a Greek extension workers, so, and it was part of the reforms by the Ransom Kuti era, to reach rural communities and also have a cadre of healthcare workers that can provide primary health care in line with the Alma-Ata Declaration. So they are to spend some time in the facility and some time in the community. The Choose helps in navigation, patient navigation, referral services, home visits, attending to children, nutritional support, elderly people, checking them and stuff. So that's like the design. But currently, because of unavailability of other cadre of healthcare workers, we started the task shifting policy, that's kind of shifting almost everything to the Choose. And we shouldn't expect too much because that's not the design of the training. So, and when we also say, okay, let's uh, make their curriculum to look like maybe physician assistants in some countries where that's available, then they choose to no longer be available for us to even hire them to work in PACs. They begin to step up because they hire the skill, the less likely they will stay to work at that level. But at the moment, they are not in good numbers from certain observations I've made. The states are not hiring. Almost every state have a school of health technology. They are training Choose, but they are not hiring them. In my state, I'm from Ebonyi. In my own local government, where we produced the immediate past governor of the state, as at the time he was living, or even as at 2 years ago, we had less, on the average, less than two skilled healthcare workers per primary healthcare facility. So some Choose have like two, some have only one, you know, manning the entire health facility. So that's even where the problem begins from. While the World Health System, by design, requires for a full PhD that should operate 24 hours to have up to 35 staff. At least 25 of them will be skilled staff of various categories that include pharmacy technicians, lab technicians, Choose, nurses, midwives in certain numbers, and they should be running shifts. Those that work at the daytime are not going. Those that work at night. Some of them will even live in the facility. So for it to be able to operate in 4 hours. But we also have like the health post and health clinic. Health posts require about 8 of such, and clinics require at least 2. So but we have a full PhD that should have like up to say in terms of those service delivery people, up to 16 of them having just 1 or 2. With that alone, even if they are excellent, even if they are superstars, there's no way they can meet the needs and services at the facility level. That of community is like non-existent. Apart from the outreach, immunization outreach that they go to some places to do with support from donor partners, so there's absolutely the health education function of choose is not happening, it's non-existent. Nobody is even talking about it. So those communities are, and that's a huge gap for me. So I think those gaps needs to be filled. Let's even have them in the right numbers. Of course, the right motivation, as Kingsley has said, and other things, and now begin to know where exactly mental health services is non-existent in primary health care. Those are some of the functions. I recently conducted a study in my local government, dementia knowledge, attitude, and practices among primary health care providers. 124 interviewed in 58 health facilities. And guess what? The finding is very much interesting. In fact, those who had any knowledge of cognitive screening tools, just about 4% who say they have the knowledge. If you even probe further to give them those tools, maybe some of them may not even be able to identify it. And some had dementia for the first time, while they're going through the questionnaire. And these are healthcare providers, so it's kind of interesting. There's a lot of work to be done, and it's at the state that most of this has to happen. Unfortunately, no matter what Abuja does, there's a certain level Abuja cannot get to. And as been stated, we have some of the best policies. Our problem is not the policies, it's the implementation. And if you talk to some professional health, they don't quite understand primary health care. What they think is buildings and procuring equipment for hospitals. When you have those who should lead it at that level, not quite understanding it, it kind of becomes difficult. Thanks,
Thank you so much, Dr. Laz. So that is to say that training and retraining of healthcare workers cannot be underscored, and the design of the curriculum needs to be upgraded to what the global standards are.
Yeah.
So thank you so much. Dr. Celestine, over to you, please. Okay. In the absence of that, I would ask one more question to Kingsley, because he is actually a digital health expert here. So Kingsley, digital health tools, and digital health platforms, electronic health records are being promoted as solutions to expanding access. Are these tools reaching the communities that need them the most? Are they widening the digital health divide? Considering that we have a lot of barriers to digital tools in Nigeria, such as electricity, access to internet, access to the digital tools themselves, the ability of the healthcare workers to use those tools, right? As well as insecurity. There are some communities that are cut off from where services are being rendered, where internet services are being cut off from. So Kingsley, can you shed some light on this question in how digital tools can be utilized in promoting solutions to expanding service delivery in Nigeria? Over to you, please.
Okay, thank you so much, Jennifer, once again, and thank you for bringing me on board anyways. So I think I think to start with this particular point, so as just to make it clear. The truth is, the aspect of digital health tool, the introduction and also the rolling out, it's quite promising when it comes to the context here in Nigeria. Well, not just because of the population, but rather because of the interest as well. But then it's sad to some extent if deliberate effort is not being channeled towards ensuring the people that this digital tool are actually meant to help, it's inversely going to create inequities to some extent. Meanwhile, the state digital tool, they say the whole compared to the state digital health is meant to address the aspect of inequities. As a matter of fact, there was a scoping review that was done in 2023 thereabouts, and it was a decade of scoping review of more than 230, and it spanned from 2010 right up to 2024 thereabouts, about 14 years. And it actually revealed that there's a significant increase when it comes to data health research and what have you. This means the aspect of mobile health and also the electronic health. But then, despite all this stuff, the aspect of the internet, the whole technology, and access to some of the platforms where it could easily, say, digital tool could easily be utilized, it remains limited, simply because of the low coverage of internet across some of these locations, and also lack of motivation. We could easily say lack of motivation is also an issue one way or the other. And one thing that we all could agree to, the inconsistency when it comes to availability of power supply could also, sadly, it's hampering the whole utilization of the said digital tool. And as a result of the lack of power supply, it hampers accessibility as well as reliability. And the introduction, or rather the use of USSD code, which is meant to really lift the burden of lack of internet connectivity. Some of the locations tend not to have access to the mobile devices where they could easily use in order to utilize the access to the said digital tool, such as the mHealth, the eHealth, and other tools as well. So just to round up to the question, while I try to give other panelists to contribute as well, the whole digital tool in Nigeria right now, we are not seeing the impact at the rural area. It's more tilted towards urban areas simply because of the increased development also. And that's actually an issue. But if you look at the whole idea behind the digital tool, it's actually to ensure those living in rural area have access to quality health and basic health services generally. So I think there is a need to be deliberate about ensuring those that the tool is meant to reach actually being reached. So these include ensuring some of the policies and other offline system are being invested in so as to ensure no one is left behind, because one of the notion behind strengthening the health system is ensuring no one is left behind. And if the introduction of digital tool is creating that inequity, that gap between those living in rural area and as well as those living in urban area, then there is a bit of a problem. So basically, infrastructure, one way or the other, we could easily say it precedes the whole rolling out of technology if we intend to really reach those people that we have in mind when introducing some of these digital tools. Thank you so much. Over from my end.
Okay, just to layer on what you said, Kingsley. So in summary, you're saying that there's inequity in between the paper-based data collection methodology and the digital data collection methodology. Do you think that we can harmonize and integrate these tools, that's offline data collection tools and the online data collection tools, considering that the national database is health database is transmitted to DHIS? So how do we close in on the gap of data loss, especially as we still use the paper-based and registers at the primary healthcare centers where these data is transmitted to the national? How do we close in on that and integrate these tools such that we capture data and they are correct and there is no loss. Over.
Okay, I think, like I said, we can't, one way or the other, become more efficient if we neglect the aspect of infrastructure, because that's the basis at which digital tool is even if would even be effective. So infrastructure should equally be prioritized when coming up with these digital tools per se, infrastructure, and also the tools needed to transmit the said data right from the community base up onto the national or whichever system that serves as a collating database for better analysis and the rest. So basic summarily, infrastructure, like I said, it's one way or the other precedes this whole notion of, we need to be innovative, because without infrastructure, without the needed tool, it's always difficult to really reach that, to really expand the whole idea behind the universal health coverage, the last mile intent in this context. Thank you.
Thank you very much. Dr. Laz, you have something to say? Before that, is Dr. Celestine back on the call? Okay, Dr. Laz, please.
Okay, yeah, thank you very much. Infrastructure is important, and of course, looking at the whole thing from the 6 building blocks of the health system. So, any aspect that is not working, it's very difficult to achieve universal health coverage. So, but thankfully, infrastructure part appears the one that tends to get the attention of the political actors more, because there is incentives for procurement and giving contracts and stuff, but maintenance and also the utilization, there is gap. I think it was 2020 December that the Ebonyi State government supplied equipment to hospitals. COVID-19 kind of made political actors to be a bit more conscious about health. So they supplied equipment to general hospitals, and they make a hospital work campaign team in my community where there is a general hospital. I was able to take inventory of what was supplied. And August 2021, I took a patient to the general hospital, and the beds and all those things that were supplied, none could be seen to be in use. They were still using very old, and so I asked questions, and it appeared it was locked up in a store. So sometimes when these things are procured and showed on TV, they find their way into a store. I also know of a teaching hospital where they bought some CT scan, and it was in the store for years. I don't think there is still it's still being put to use because they're reluctant to train those or hire those who can use it. So these things are kind of all related and all interlinked, and we pray we're able to get those who will be very serious and for there to be consistency. Because right now, for example, I can use Abia as an example. The governor has some experiences with a loved one using health facility, and that kind of inspired his interest. During COVID-19, he personally called the CMD of or the medical director of FMC in Umuahia to say, "Oh, how can we be of help?" And mobilized some resources and supported FMC to do certain things. Just based on that personal experience, and because of some of those things, it's kind of paying some kind of attention. But would that continue after him? It's usually the problem. Sometimes you make progress and another team comes in and you tend to lose almost everything. So, but if you could have systems in place that will be less affected by some of these political changes, like Celestine said, I don't know whether it will be in the next 500 years. So, but I sincerely hope it shouldn't be that long. All of us are putting efforts. We are spending our time talking about this. But I should also appeal that, because I'm probably the only one that is still in Nigeria among those people on this call. So if all of us they come out like this, it might take it 2,000 years for us to get it right. So, but I know that we are making contributions anywhere we are, and at community level, if we can start paying a bit more attention, take up roles, encourage our communities to set up health committees. I've successfully gotten my community to set it up. When I accepted to be chairman of the committee, I've been running away from that, and they refused to set it up. So until I accepted the set up health committee, oh yeah, come on, those things you are preaching, come on, practice it. So we keep pushing and hope for the best. Thank you. Over to you, Dr. Jennifer.
Okay, thank you so much. I love the direction of this conversation because it's actually going to address a lot of gaps and it's giving us insight. We have a lot of partners who are logged onto this call who are also taking key insight from our contribution to the discussion of today. So over to you, Celestine. After your contribution to this question, Marybeth would continue as taking the last set of questions for you. Over to you, Dr. Celestine.
Okay, thank you. I really wanted to touch on the telemedicine and to be honest, one thing, so there's something I don't really know yet. If, Nigerians, the government, especially, those in the ministries and close to the people in power, if they really know maybe there are cheap ways to go about some of these things. I will give a classical example of what we did. I'm actually the one that led this innovation. So I'm coming from a practical angle. Now we designed a tool in Ukraine that people could use to access, medical care remotely. And I can tell you that the premium we pay for this tool is about, if I calculate everything, it's about $40 to $80 per month. Right? This is, let's just say $100,000 per month. 100,000 naira per month. And this tool will be available for everybody to use. Everybody. Again, some of this innovation doesn't really cost a lot, especially if the people doing it are sincere. Now this I'm telling you that is about 100,000 naira that can serve the entire population of a state. But somebody can come and tell you, and after a lot of analysis, it can run into billions of naira. Again, most times these Europe guys are quite sincere. We've not gotten to that level of sincerity. Can this be done? Yes. Again, I was discussing with someone. I was asking, do we really know that such a thing exists? And the good thing about it is that these services can be delivered via the WhatsApp, which I know that a lot of people, not everybody do, but I know that a lot of people have access to WhatsApp and WhatsApp messages, even in the and internet, even in the rural community. Again, this can be done even via voice notes, or for people that are not literate, they can use their voice, and it must not be in English. You can use their language. AI has been able to. This was actually done. It was an AI incorporated something. I personally presented this at the Global Nutrition Cluster, and then we also published this article. Again, unfortunately, I'm no longer with the maybe Nigerian NGOs and health sectors. Probably this is one thing I feel an innovation we could drive, that can help us to get some of these things that we are saying up to the rural communities. Especially, first of all, it's going to give us the leverage to, to disseminate health education easily. Everybody can now access this thing 24 hours 7, and it can also signpost people. When they see danger signs, they ask their telephone, they just press it or they just drop a voice note. The message will tell you, oh, because of this, you need to go to this health center or you need to go to the teaching hospital. Again, we did it in such a way that this AI could even tell you, oh, for this, you need to go to this health center, the one closest to you, in case that you are new to that area and you don't even know the facility, that is within your geographical catchment area. Your phone will tell you, please, you need to go here. And I'm talking about just mere 100,000 naira, which I'm very sure that the government can do. Why I say the government is sustainability. Just like I think it was Lad that said that we've all been in NGOs that we run projects, but by the time the whole thing closed, everything collapsed. So most times sustainability is not just it's because it's 100,000, let one NGO anchor it. when it gets to the government, because all these referrals is going to still go either to the government or the private hospital for sustainability. Asking Dr. Lazeze, I know that you are still here. At least you talked about the IVR transition. This is something that you should tell them. It's very cheap. So I'm just trying to be real. It's very cheap. I did it. I led the innovation, so it's not like something I read in the books. This is something that we can even discuss off this platform, and we can start from there.
Yeah.
Because another thing I also noticed is that we do a lot of meetings. We do, but I want to translate this in very easy things that we can do. Like, this is not the first time we are going to be having calls like this, and this is not going to be the last time. But now, how practical can we make this? Like we've discussed the choose. I will tell you something. I always tell people something. The very first twin delivery I took as a doctor, the very first twin delivery I took as a doctor, it was a chew that practically did that for me during my NYSC days. In fact, it was midnight. There was nothing like we are not going to refer. It's two things. Either we handle it ourselves or we allow the woman to die, because it was quite remote. There was no even to start referring anybody to anywhere. How are we going to train the choose? Yes, if we build their capacity more, they'll become something like maybe equivalent of physician assistants. They can still live or even jabba, who knows? Again, are we going to leave them at the level where, a CHU can just be doing anything anyhow, or there is no job? Again, it comes to the structural problem we've all been talking about. My own suggestion, in that particular one is we can't stop training
We lost him. Can anybody hear me? Can you hear me? Can you hear me? It seems I'm lost.
Yes, Jennifer, you have been heard.
You can be heard clearly.
Oh, okay. I thought my internet had gone off. Okay. Okay, everybody is back. Okay. Okay, so Mary Beth would lead the next round of 2 questions, and then we would open the floor for questions and answers.
Is Dr. Celestine back?
Okay, so while Mary Beth is getting herself put together,
Can you hear me?
Yes, I can. Okay,
So
before you go, please, just a minute. Dr. Laz, we will have a conversation offline on the digital tools, because there's also another digital tool that was developed by Dr. Adebayo, which is being piloted across Abuja and Oyo states at the primary healthcare centers. So we're going to have a conversation and see how we can work with also Celestine to see how we scale up, integrate and scale up these tools to see how we can solve some of the problems in the country. Thank you. Over to Mary Beth.
Thank you. I was asking if Dr. Celestine is back, because my question is channeled towards him.
Okay, Dr. Celestine, are you on the call?
Yes, I am.
Thank you. Thank you very much. So when you were speaking, you mentioned about the financial mechanisms or health insurance that you also spoke about. And I think my question really is that what would you advise in understanding the various levels of financial mechanisms such as taxes and bonds that are being brought into which of them do you think would be adaptable to the Nigerian context, understanding that majority of Nigerians are working in the informal sector, and also the gender dynamics, which is kind of key in this discussion. So, which financial mechanisms would be the most applicable and most realistic to work in Nigeria? Over to you, Dr. Celestine.
I don't think he's on the call.
Would you like to take the question, Dr. Laz? What would be your opinion on that?
Okay, so
Can
that's
someone hear me?
okay.
Yes, can be held.
Okay, there's some hitches with the connection. Okay, so I didn't get some parts of the question. Can you quickly repeat it?
And so I'm saying that with the present health schemes, there are also like financial mechanisms that are being introduced at the moment, such as the taxes, and some of them are also suggesting bonds. But I'm really asking that with your understanding of Nigeria and the different dynamics, both in gender, majority of Nigerians are working in the informal sector. What do you realistically think would work for Nigerians, then vis-a-vis the different dynamics that are taking place?
Okay, yeah, thank you very much. Yes, a lot of things have been deployed, taxation, some say sin taxes. I was one of those that pushed for more tax on sugar sweetened beverages, SSBs, to get more funding for health. But, there was an increase, but there was no policy framework to say, oh, this additional money should go to health. So, which means the money might be used to buy cars or computers or some offices. Um, yeah, but in the whole dynamics, I begin to think we do not even get enough value for the monies we are spending in the Nigerian health sector. For years I've been part of increased money for the health sector, sustainable immunization financing, more money for health, Abuja Declaration. I've strongly involved in that advocacy. But when we engage the budget office in the Ministry of Health, there's one question I usually ask us. Every time you health people, you're asking for more money, more money. But even for the one that is allocated, the one that is released in the budget, the Ministry of Health don't use everything. Sometimes they refund money. Even though there's arguments about the timing of the release. If you start releasing annual budget from October and they just have 3 months to spend it, then they won't perform miracle to finish everything. But generally speaking, my idea of tax, I'm not sure I'll be excited to jump on supporting additional taxes for anything at the moment. I want to see more better utilization of even the monies we are putting in, getting more value for money. In terms of digital health, yeah, there's so many technologies are being deployed. Within the immunization space where I work, I could see how data technology is used to track everything up to the point of tracking teams, from seeing whether teams actually go to the locations they are supposed to be, to even have technologies that track whether the vaccination teams visit households, whether they enter the houses to come out, So, which is quite fascinating. There's a whole lot that could be done in promoting accountability, in ensuring that things are done properly. But the health space is Like in our parlance, they say any goat that has many people that are feeding it will die of hunger. A will think if I don't feed it, B will feed it. So because of the nature and the responsibilities are not, in a lot of cases, very clearly marked, federal, state, LGA, everyone is doing health, no clear demarcations on who is responsible for what. So a lot of talking and less of action. And when states, when they want to, we tend to mention federal more, and the states will just be there. Meanwhile, they have more work to do. So I think it's just to insist on more value, getting more value for what we have, asking more questions, and getting more answers in terms of everyone playing their part. There's even the donor space sometimes, some instead of strengthening, kind of tend to create parallel systems that may not add so much value to them. I have a meeting in 6 minutes, so I may be leaving you guys anytime soon. Thank you.
Thank, thank you very much for the thank you for the response. And I think like if I can just summarize it in a sentence, it's like more focus on the utilization of the value that is already there than generating or asking for more money or more returns. And I think that's very key. That's very key. Thank you. Over to you, Dr. Jennifer, for the Q&A session.
Okay, thank you so much for the amazing session. This is quite insightful. And panelists, you have actually, we had a deep dive on what are the barriers to universal health coverage in Nigeria and some of the actionable points that can be taken to ensure we improve universal health coverage in Nigeria. One key thing that I didn't hear very loudly is the role of the NOA. Is that it? National Orientation Agency. You need to have and integrate an overlap between most of the agencies and the NOA so they can amplify the voices of the healthcare workers, sensitize Nigerians to accessing health insurance and all that, just like it happened during the COVID-19 where we were receiving information, disease notifiable diseases, all that information on our devices. We need to work closely with these agencies for them to act on their mandate on how to sensitize Nigeria and improve communication efforts on ensuring that the right information reaches the people and not misinformation. Okay, thank you so much, everyone. We open the floor for questions and answers from the general public. Please, you can type in, you can chat in, you can mention, you can use the voice and let us answer your questions before we call it a day. Thank you for staying up until this time. It's actually very, very, very important to us that you're still here up until now. Thank you. Over.
Okay.
And while we're waiting to take questions, maybe from the chat room and anywhere else, it would be good to get Dr. Laj's insight on health worker health facility ratio. How do we close in on this gap when it comes to universal health coverage in terms of funding, in terms of release of funding to primary care? How much can the facility use to generate, how do facilities generate their own income to be able to close in on gaps around utilization and service delivery? Over to you, Dr. Laj.
Yeah, sure. So I think the very first thing is the way our healthcare system, the primary healthcare is funded is too complex. So you need to spend time actually just simplifying it. All over the world, primary healthcare is best funded close to utilization. So it's interesting why funding it from the state and federal level. It's not a complex healthcare to deliver. So if it's not, you don't need people that design it to be funding it from a very far away place. So that's the first thing. So at most state. Now, the other thing from the government end is if an agency is supposed to be what decides on something, then that should be respected. If it's a function of the state, it should be. So I think that's on one end. The second broad problem with healthcare generally is the issue of health insurance. And I think we need to sort out the legislation. And I'll give you good examples where they've done it simply and they've done it complexly. In much of Europe, primary healthcare is almost like right because it's funded from general taxation. So if you live in the UK and you are a citizen, automatically you get access to primary health. Therefore, there's funding. There's debate about whether that funding is enough or not, but that's a conversation for another day. So, but that sorts funding. So you are not running around looking for money. So you need to sort out the legislation in Nigeria that makes it compulsory, not optional. Now, the same Nigerians, when they come to the UK, you take health surcharge, isn't it? Until you no longer, you've paid enough tax. So that's the first layer. You can take the US model and say, fine, we would look at how much insurance you get based on how much you earn, which again, but then that's compulsory. I won't go into the discussion of undocumented migrants in the States. But the way it's been designed in Nigeria on purpose, government has made it optional, and we continue to allow that. So that's the first thing. You need to sort out the funding. So they need to be sponsoring bill that makes it compulsory to get health care. Yeah, in federal health, even if it's federal health insurance, that would go a long way. This concept of we're going to subsidize the healthcare, which is what they are doing now, is failing miserably because the cost of modern healthcare is just extraordinary. So once you have that law in place, you get the banks to come in. We have everything. All these ones, they are saying there's no infrastructure. It's a scam. We have more than enough infrastructure because our banks are working. Nigerian banks work just as much as any bank anywhere. Yeah, so what you do is the banks come in, they help you market this health insurance. Because it's compulsory, you find a way of collecting the money, using a deficit system. So immediately the person engages with anything, the easy informal sector, as long as they have a phone number, you've already asked telecommunication to put it at a debit. Now you have the money. The second layer of problem is, now how do you prevent corruption? How do you prevent this money from being stolen? Yeah, there are other ways to do it. Now the next step is we can copy from the US or anywhere. Now the reality is the level of care you would receive in an NHS hospital or a private hospital in the UK is largely the same. Yeah, because the regulatory standard is almost the same. I don't know if you get what I mean. You get me? So there's no point. So whether it's missionary, whatever, it's just the speed of access. Yeah, so if I don't want to start making line and all of that, you know what I need? I have an elective problem. I want the operation done next week. Fine, I go to the London clinic. They organize in 2 weeks done, and then I have the money to pay. Now, if it's in the NHS, but the standard is largely the same. Now, that's the problem we have in Nigeria. The standards vary so much across medical schools, across teaching hospitals, across state hospitals, and roughly As it goes towards federal, the standard improves. Yeah, the competencies, what they check, the behavior, everything, the training, the quality. So that has to improve. And then once you bring anyone registering, whether it's private or public, doesn't matter. Once you ensure that the standard regulatory bodies are doing what they are supposed to do, then we are getting it right. There's also the issue of proliferation of regulatory bodies. Yeah, we need to be clear who regulates what. Yeah, so if you have a body that regulates hospitals, fine, that's their job. So now wherever that hospital is, they regulate. But you have some confusion around, like I'll ask you now, who regulates federal hospitals in Nigeria? Hello? Mary Beth. Since you are not in, who do you think regulates federal hospitals in Nigeria?
The federal government.
Okay. Who's on the call? Celestine, who do you think regulates federal hospitals in Nigeria? Jennifer, what do you think? Who do you think regulates them?
It's the Federal Ministry of Health.
Really, there's no clear-cut agency that does that.
There's no single body that regulates.
Can you see where the problem is coming from? Yeah. What you have is you have bodies that regulate the practitioners, which is one level of regulation. So that's the problem. Then you have bodies that regulate the training, which is, so you have midwifery council. If you are a nurse and midwife, is in your pharmacy council, MDCN, yeah? Then you have the postgraduate college. If you are training, and in their own wisdom, they believe that will make sure that's enough. In most places, you have indirectly the Federal Ministry of Health under the Department of Hospitals or whatever have indirect control.
Yeah.
But you need to have, like in the UK, you have the CQC, Quality Care Commission. Yeah. You need to have a regulatory body for hospitals. Now, you need to be clear, do we want to make a bilateral one, meaning state and federal, or do we want to make, so state government sort themselves out, federal government sorts themselves out, which may be better. You get me? And then they work together as needed. But I would prefer a single agency, you get me? And then the state can. And that regulatory body, everybody falls under federal, state, private hospital.
Okay, Dr. Lai, yeah. You have 1 minute to wrap up so we can check on comments.
Yes. So I think this is my key point. So we need to get the money in. We need to get the regulation in, because that's the only way you would modernize the healthcare. You can't. For instance, we are so behind with anything minimal access surgery. Yeah, we're so behind, and we keep opening orthopedics hospital. How many people will break their legs? Why do we have so many orthopedics hospitals and we have no minimal access hospital? We don't need, in fact, they opened more. So I think, I don't want to spend too much time, but I think this is it. We need to get the funding right. We need to get the regulation right. Okay. And then we need to also get, accountability and corruption sorted. And then things will begin to improve.
Thank you so much, Dr. Lad, for the insight. Mary Beth, do we have questions in the comments from the general public?
Yes, we have one, but I think it has been adequately answered. How do we stop CHW from asking caregivers to pay? He wanted to say Trey. How do you stop Trey from asking caregivers to pay? what measures should be put in place to check that? I think that's the question in the comment section.
Okay. Kingsley, do you want to take the response? Mary Beth, you said the question has been answered already.
During our discussion, we discussed like empowering the trees and trying to make them to have increase their capacity so that they are able to take care of themselves. And I think that was around the discussion of empowering them more. But I'm sure more light can be shed in terms of like what measures should be put in place to check that.
Okay, in terms of measures that can be put in place, it's about having quality control measures, having tracker tools that can be used to monitor and evaluate the impacts of what measures have been put in place generally. So thank you and over. So we would have to bring this session to a wrap.
I think, sorry, Jennifer, just to add to that, I think supportive supervision can also play a pivotal role from, let's say, high-ranking supervisors, because that will kind of, it will send the message that you guys are not the only one, to some extent, manning a particular facility. We are all in this. So when that perspective is changed, there will be a massive change. Thank you.
Okay. And as well, in addition, coaching and mentorship would also help. So when you have one-on-one coaching and mentorship, you have learning review platforms where you bring them together to learn from each other, like peer review. It will also help to address these gaps. So as
I also think that there could be a form of like whistleblowing mechanism where people that have suffered from abuse can, of course, report such situations anonymously, and then
I agree with you, Mary Beth, but the thing is, you cannot easily punish people when the system has not done the minimum. So the problem with us is like in the UK, you do something to give you maximum punishment. Why? Because let's say, like now, they call me, say, oh, we think, look, the SHO calls me, I think patient, I don't understand. Okay, fine, scan. I'll call the on-call radiologist. In 2 hours, we have CT done. Hello?
Yes,
I'm just telling you, in another 2 hours or 3, we'll get theater space. We started the operation. Yeah, let's say we are confused. We're not sure. This is confused. Same thing with spine. So until you bring in enough money, you can, then that's just torture. In a way, I'm not saying, so we know the government in Nigeria know rift is happening. The reason why they are not using hammer to beat up anybody is because they've not done the minimum. It's different with Chimamanda's son. Yeah? Because the reality is, if they had a clear structure and regulation, why is it very easy for someone to go outside protocol? Why would you use propofol just to do a CT in a child? If you needed to do it, if you think it was that important, why wouldn't you just intubate the child? So until those minimum are there, they know that they cannot be too heavy-handed. I don't know if that makes sense. So that's the issue.
So, Dr. Ladd, in addition, during the past administration in Nigeria, there was a centralization of payments in Nigeria into the single treasury account, which was aimed at blocking leakages, financial leakages from government-owned institutions. All payments were synergized, were harmonized into the Remital platform, where you issue all those payments to block leakages. However, the leakages continue to subsist.
Hello?
Hello.
Yeah, you can hear me. Yeah, go ahead.
So the leakages continue to subsist, and it still has not addressed the corruption across board.
Yeah. until there's a clear-cut work towards dealing with why, because we know why the system is not working. Hello?
Yes, we're here.
Yeah, and you don't need some spiritual delivery. There's NHS fraud. You steal the money, they'll come after you. They collect all the data. It's going to take some time, but they eventually catch up to you. So it's not like we don't know why it's not working. One, if you don't collect the data, they know why they are not collecting the data. Because when I was a medical student a long time ago in ABU, when the Americans ran PEPFAR, they sent the data the same day to America in real time. I was a medical student last 15 years ago. Hello?
Yeah.
Is Daria? So what are we saying? The same day as they are collecting the CD for whatever, that evening, the director of the program in Maryland University has all the data. You get, but if you go now to any of our hospitals, there's no even good record that you've attended. There's no good record that this is the time you came, this is the time you were seen. Hello?
Yeah.
There's no good record of what medications they gave you. So until you fix, those things, EPR is sorted, until you fix. And then if you get a job in our hospital, I don't know about you, but when I worked in jobs, I didn't have a job ID. I have now maybe 4. IDO, how the access doors. If you go to the hotels in Abuja, they give you this tap card, this same country. But the hospital, anyone can badge you, and kill you when you are trying to treat your patient. So, thank you. So, until, I think I've pointed some of it. So until the system starts doing the bare minimum, it's a bit of counterintuitive to say, oh, that's why they are not punishing anyone.
I want
you
to
get
believe,
me?
Yes, thank you so much, Dr. Lan. I want to believe that it's our collective effort that is going to bring about the change that we desire, which is the reason why we are on this call, bringing in technical expertise, wealth of experience to ensure that we actually close in on the gaps in universal health coverage. And as we close, in summary, we have got to understand that Nigeria does not lack policies, but it struggles with implementation and coordination. And our finance system places a disproportionate burden on individuals, particularly the poor and those at the rural communities. And at the community level, the promise of universal health coverage often breaks down due to weak service. But we've also heard something equally important, that there are solutions that exist, which are inexpensive, by the way. And that means that universal health coverage is not just a technical aspiration, it is a moral obligation of all Nigerians to ensure that whether a farmer can access care without selling farmland, a pregnant woman in Bauchi can deliver safely without having to sell her assets, a child in a rural community can survive preventable illness. And we need political backing and commitment backed by funding and relief. We also need systems that work across the federal, state, and local government level. And we need communities at the center of the health system. And with that, I'm going to close by saying that universal health coverage is not just a gift that governments give to us, it's our rights. And it must be demanded, fulfilled, and built together. Thank you, everyone, for coming on for this roundtable. It's such an absolute delight to have been your moderator for this event, and my co-moderator, Mary Beth. Thank you so much, including all the panelists, and our host, Dr. Laj. Thank you so much. See you all on the next roundtable. Have a great week and a great day ahead. Bye.
Bye.
Bye.